ethnicities who had some cardiovascular risk. About 20% had a 10-year Framingham risk that was elevated over 15% in that population. So they had some risk factors, or they were just 75 years of age or older for that. Randomized to intensive therapy or standard therapy, you can see right away the intensive therapy dropped the blood pressure about 15 millimeters compared to standard. So standard therapy, you can see on the top, was an achieved blood pressure of 136, and in the intensive care, it was achieved blood pressure of about 121. Lower than we'd usually recommend, lower than our guidelines for older individuals, those over 60. So it was sort of innovative to say, pushing blood pressure lower, does it make a difference? So many of us will get old, over 50 during our lives, and perhaps many of us will get over 75 years of age. So this applies directly to us as we look at the data. So what did intensive therapy mean for those individuals? It meant a reduction in the primary outcome of stroke, myocardial infarction, heart failure, or death. You can see that the curves here, if I get back to my pointer, the curves here start separating at 1 year and continue to separate thereafter. So if you want to prevent stroke, heart attack, heart failure, and death, intensive therapy in an older individual makes a difference beginning at 1 year and continuing thereafter at that point. So there is a benefit in reducing cardiovascular events in this population. And if you look, you can see the number needed to treat is 61 to prevent one event in those individuals for them.
Just to emphasize that point, can you talk about the 0.75 hazard ratio?
So a 25% reduction in cardiovascular events in the group, that was, the trial was stopped early. It was a 5-year trial. At 3 years they said, hey, we've seen enough. We have to stop the trial early to make sure that individuals on standard therapy know that they can reduce their events if they're on intensive therapy. Number needed to treat 61, and the relative risk reduction was 25% for that, for the cumulative primary outcome. So clearly benefit, and the benefit starts at approximately 1 year and continues to diverge thereafter. If we look at the individual primary outcomes, which are shown here, get back to my pointer, you can see the primary outcome resulted in saving about 2 events per 1,000 per year. So it's a small benefit, but you're going to save 2 events per year of primary events. Those events are MI are reduced, strokes are reduced, heart failure is reduced, and cardiovascular mortality is reduced as well. Cardiovascular death goes down significantly. It goes down, as you can see, about 43% in that group of individuals. So these are significant reductions. Now, if we look at 0.54, which is the separation or absolute risk reduction in these individuals per year, you can see that we'll save about 5 or 6 individuals per year of intensive therapy compared to standard therapy. So it's a small number, but if you can tolerate this medicine, why not accrue the benefits of lower mortality, lower stroke, and lower myocardial infarction in these individuals. Now, the benefits are clear. 25% reduction seen across all subgroups at this point in time. And this is a forest plot that clearly shows us that the line of unity is here. Every one of these dots for every one of these groups is on the line favoring intensive therapy at this point. And it favors therapy for those over 75 or under 75 75 equally well, all ethnic groups as well, is whether your blood pressure when you entered was just 132 or whether it was 145. Yes?
So previously in this room, it was presented that for older patients, the concern was that they would fall and that they would have all-cause mortality.
We're getting to that on the next slide.
But your slide shows that it's that greater than 75 group benefits even more, right? So I just
Correct.
wanted to emphasize that
Correct.
for those who've been here for a long time.
Yeah. And the reason the over 75 benefits just as much is they accrue, they're a higher risk at that point, and their absolute risk is slightly better for absolute risk reduction. So that's the benefit of reducing cumulative stroke, heart attack, heart failure, and death. How about just death alone? So if we look at just death alone, it's shown here, and we can see that there was a 27% reduction in all-cause mortality. So I always like to look or throw in all-cause mortality, because if something else is happening, accidents, cancer, something else off the wall, this will reflect it. No, there was no significant increase. In fact, a 27% reduction in all-cause mortality tells us we're doing the right thing. We're living longer, having fewer mortal and fatal events. Now, I will point out, though, that the reduction in all-cause mortality starts to diverge at about 2 years instead of 1 year with cumulative events. So if you want to reduce all-cause mortality, you've got to be on the therapy for a year or two before you'll start accruing the benefits. Now, what that means to me is if I see a patient in the hospital, I see a lot, the question is, do we get their blood pressure down today or tomorrow or next week? You have time. You have time because the separation of these curves is a year to 2 years on therapy. I don't have to get your blood pressure down today or tomorrow, but I want to know that I'll have it down a year from now and 2 years from now, well, where you will accrue the benefits of fewer events in that situation. Number needed to treat is 90 to prevent one all-cause mortality in those individuals. Now, all-cause mortality, again, here's a forest plot. You can see all of the dots lie on the side favoring intensive therapy here. So whether your blood pressure is high or low, you're over 75 or less, you get a benefit across the board for it. So the good news is this works in the spring trial for all the individuals who are 50 or older entered into the trial with some cardiovascular risk or age over 75 in that group of individuals. Now, those are the benefits. 25% reduction in events, significant mortality reduction as well. The question is, what price do we pay for that improved efficacy and response? And it's going to come up as side effects, which I'm going to show you here. Yes?
Have you articulated what the intensive therapy is?
So intensive therapy is a goal of getting the blood pressure under 130. And the achieved blood pressure, I showed the slide, in the trial group was 121.4 in the achieved therapy. So their target was to get them under 120. They did not achieve the under 120. The achieved blood pressure was close. It was 121.4 in that trial. Versus standard therapy was to get it under 140, and they came out with a blood pressure of 136. So the difference is an achieved blood pressure of 136 versus 121, and the intensive group was the 121. And they did it by adding an additional medicine. So they were typically on 3 medicines, whereas the standard group was on 2 medicines. All of the individuals had what's called lifestyle modifications. Those are encouraged for everyone across the board. So what do we pay for this benefit of fewer strokes, heart attacks, and deaths? Well, you pay for it potentially in side effects of therapy, more intensive therapy. So here is the fact, therapy side effects shown here, really no difference between standard and intensive for all side effect, significant side effect reports. There is a difference, though, that you'll see in both hypotension and syncope, a small bump up in syncope and in hypertension in those individuals. So if we put these individuals on more intensive therapy, they are going to notice a small bump up, 1 to 2% absolute increase in hypotension, meaning dizzy when you stand up quickly, or might pass out at that point. And if you look at these numbers and we balance them, we'll see that the number of increased hypotensive or syncope events pretty much balances the number of reductions of strokes, heart attacks, and deaths seen. So it doesn't come free. There are some side effects in these individuals, but I ask you, would you rather have an irreversible stroke or death or heart failure or MI, or a transient syncope event, which as soon as you slump down will be reversed and goes away in those individuals with no increase in mortality or fatal strokes in that group of individuals. So we're trading off a significant benefit, mortality, heart attack, and stroke reduction in return for some symptoms that could be bothersome to the individual. How do we deal with that in those few number of individuals who are, in fact, having symptoms of hypertension or dizziness, and we're going to talk about that at the end. So those are the side effects. The injurious falls were actually less in the intensive group than in the standard group. So there was no increase in falling down and injuring yourself because of hypertension. So quickly to summarize this, we can see that the SPRINT trial looked at intensive therapy, achieved blood pressure 121 versus standard achieved blood pressure 136 of individuals over 50 years of age. Many of whom had an additional risk factor or were over 75 years of age. They maintained the blood pressure difference throughout the trial. The trial was stopped early at 3.2 years because of the tremendous benefits seen in the intensive group, with 25% lower overall complications and 27% reduction in all-cause mortality in those individuals. And the treatment benefits extended to all groups, ethnic groups, ages, genders. In those individuals, there were some side effects that were associated with it. No overall difference in side effects, but there was more, as we can see, hypotension, syncope, and electrolyte abnormalities, all of which were temporary and reversible in this trial. So the feeling of the SPRINT trial was that the benefits in reducing stroke, heart attack, mortality, and heart failure were achieved as a net benefit over the transient side effects of hypertension and syncope in a small number of individuals, and the net benefit overweighed the side effects associated with this in these individuals. And again, other publications have come out and suggested that among patients, as we can see on the bottom here, because of these benefits, among individuals who have hypertension and have a risk of cardiovascular disease, and there was no diabetics in this population, targeting a blood pressure of less than 120 and achieving a blood pressure of 121, as compared to a target of less than 140, resulted in lower cases of fatal and non-fatal major cardiovascular events and death from any cause, although significantly higher rates of adverse events were observed in the intensive treatment group. So that is the summary of the SPRINT data. Now, I mentioned in retrospect. The SPRINT trial excluded patients with renal disease, and it excluded patients with diabetics. Why? Well, they felt that there was data on those already, so they excluded them. But let's review, because you'll have diabetic patients and others that you'll see, what the population showed. So here's the latest study on diabetics. And what it shows is in purple that you'll see here is the optimal blood pressure curve for a diabetic. You can see death from any cause. The lowest for a diabetic is a systolic blood pressure of here of about 130. So 130 is also acceptable for diabetics, and we'll talk about it when we get to the guidelines. In reducing death from any cause, in reducing myocardial infarction, here's purple, even lower blood pressure is better. The curve continues to go down, even down to 100 blood pressure here. So lower blood pressure reduces MIs in diabetic patients with that. Heart failure also goes down to a blood pressure of about 120 here. And you can see that stroke goes down, continues to go down, certainly to a blood pressure of about 110. So for diabetics, under 130 clearly is seen in the data as well. So we're not going to change our recommendations for diabetics. We talk about individuals who have atrial fibrillation. Those have been studied as well. They were not included in the SPRINT trial. How about those individuals? The data shows major cardiovascular events in atrial fib. Best blood pressure, 120 to 129. Same target range we're talking about. Death from any cause, 120 to 129. Intracranial hemorrhage goes down further, so there's no blood pressure too low to reduce intracranial hemorrhage. Ischemic stroke, again, 120 to 129 is protected. MI and heart failure, again, 120 to 129 in that population. So these numbers of 120 to 129, i.e. under 130, have been shown to be helpful in a variety of diseases, including diabetes, atrial fibrillation, renal disease, as well as the population over 50 years of age. So we will recommend, and we'll go on when we get to our final guidelines, that under 130 is a pretty good target based on the SPRINT trial and our other studies. Now the question is, how do we measure that blood pressure, which we talked about earlier? And I mentioned that you have an office pressure, you have home pressure, and we have the recommendation of the U.S. Preventive Care Task Force and the ACC-AHA is an ambulatory blood pressure. The ambulatory blood pressure, as you can see here, is about as much as twice better than an office-based blood pressure for predicting events in individuals. So if you want the best blood pressure goal, as you can see here, in individuals with masked hypertension, it's almost 3 times better than an office-based blood pressure. And for white coat, it's almost double. For sustained blood hypertension, almost double. It's anywhere from 2 to 3 times better than a single office blood pressure in predicting events in these individuals. Now, based on the trials I showed you and the SPRINT trial that came out, what are our current guidelines that we're going to use for recommending treatment of hypertension? Well, here are the guidelines that rate from 2010 to 2014 on hypertension. And here are the numbers in the central column here of recommendations, and it varies from 130 to 160 as you go down the list here for blood pressures, or 150. So anywhere in that neighborhood, 130 to 150, are certainly recommendations that have come out in the last 5 years from a number of groups: the 2014 hypertensions, the European Society, the Canadian Society, the Diabetic Society, the Kidney Society, the European Society, and the Hypertension in Blacks recommendation for guidelines. So 130 to 150 are those recommendations with treatment goals there. So does SPRINT change any of this in these individuals? Well, we now know also that JNC8, which came out as a partial release, because JNC7 we'll go over, was the recommendation of 140 over 90. JNC8, which came along, took a different curve, and they said 140 over 90 was okay, but in older individuals over 60 years of age will go to 150 at that point. So JNC8 was like your recent Senate Judiciary Committee. They couldn't decide. They couldn't decide, and they never came out with JNC8. It is not a guideline that was ever released. Some of the members of JNC8 actually did publish an article from part of the committee recommending these guidelines at this time. And half of the people on JNC8 walked out and said, we're not going to endorse those guidelines at that time. So what did the Joint National Committee run by the NIH recommend? They said, forget it. We're rolling it over to the ACC/AHA guidelines. They're going to make all future guidelines. We're not going to have a joint national group at that point for that. The European Group Society, and this is currently 2018 European, also said, well, 140 over 90 is okay. So they were going along with JNC8 at this point in time, 140 over 90 in those individuals. Unless they have diabetes or renal disease, where they said it could be lower. So there was some controversy based on that. Now, along comes the ACC/AHA, which is to replace JNC8, transferred by NIH to these two groups, and the ACC/AHA brings in 9 professional societies for guidelines. Now these guidelines are shown here as basic guidelines, and if you look here, you'll see that over here, it's 130 over 80 in all of these cases for the blood pressure goal, based on pretty much sprint data, as well as some of the multiple other trials we have. So our new guidelines have dropped from 140 over 90 to 130 over 80 as our target in all of these individuals. And this would be the goal that we would aim for with everyone, unless you are, in fact, younger and under 60, and you have no hypertension or no cardiovascular risk factors to go along with it. In which case, we'd say you need to be diet and exercise to lower your blood pressure, and not necessarily medicine. But our target goal is always going to be under 130 over 80 in this group of individuals, with either diet and exercise alone or diet and exercise plus medication. Pretty simple. We don't have to remember a lot of numbers. It's under 130 over 80 is the lowest risk in these individuals. So I've put this in what's called a basic guidelines, hypertension guidelines here, as part of one of the co-conspirators here is the California Department of Public Health. And they asked us to put together a report. This report comes with basic guidelines here. And what is the reason for basic guidelines? Well, I'm going to show you a lot of data, but the basic guidelines allows us to consider putting this on a single pocket card, which we've prepared for the CDPH at this point, where you can have it in your pocket, you can pull it out and check on these things without going through a lot of machinations to, in fact, achieve that. And of course, I left one of my pointers over here. So this is available, and it's on our website, and it's available as part of a full report to the CDPH. And you ask, well, why do I put it on a single card? Well, the reason is the actual report to CDPH I have here, and this is our report to CDPH. And it's a little bit big, so if I'm a clinician seeing patients, It's a little hard for me to fit this in my pocket, and the small pocket guide is going to be a lot easier at that time. So we have basic guidelines that cover most patients, and then we have the detailed ones for those individuals where we really need it. So we're going to flip through some of these guidelines. These are the actual guidelines that are published by ACC/AHA, and it looks at normal blood pressure, which is for us under 120. The best blood pressure we ever had in our epidemiologic studies that we did was a blood pressure of 115 systolic. So under 120 carries the lowest risk of an event, and that's normal. Elevated blood pressure, is now considered individuals who have a blood pressure of 120 to 129 is now elevated at this point. So that requires diet and exercise in that group of individuals. Stage 1 hypertension is 130 to 139. Stage 2 is over 140. Now remember, previously we looked at thresholds of 160, 150, 140. All of these new thresholds and goals are significantly lower than that. Now looking at that, you can see that we have much more to deal with hypertension today. Because if we look at the old criteria of 140, and we look at the number of individuals who had hypertension, it was from roughly 11 to 70% of the population. Now that goes up to about 20 to 80% in the population, depending on age and ethnicity for it. So we have a lot more hypertension to deal with today in trying to achieve that. If we looked at how to measure blood pressure, certainly an office-based blood pressure is a reasonable target that you can see here. But here are the recommendations for 24-hour blood pressure, daytime blood pressure, and home monitoring of blood pressure. So it comes out in the guidelines with those specific items as well. And I won't have you memorize each of those, but those are very important. One of the important things of the guidelines is a recognition of what we now call white coat hypertension, which I think we're all familiar with. That is in the office, or at home. In the office they have a high blood pressure recording, but at home or during the day and night they don't have hypertension. We want to avoid treating those individuals. But the other group is masked hypertension, which I have a lot of patients with. They come into the office and their blood pressure sitting down, 5-minute rest, average 3 times, is okay. But yet they have left ventricular hypertrophy on echo or other things. I know they have to have hypertension sometime. I put an ambulatory blood pressure cuff on them, and I see during their departmental meetings, their blood pressure goes significantly high. I don't know what is about it. Some of these are chairs of department, and they still get a high blood pressure at that time. If you're not taking your blood pressure during all periods of the day, you may miss masked hypertension at that point. And that carries a significant risk for these individuals. So, things that include, and these are listed here, we went over them earlier, socioeconomic class, risk factors for hypertension being overweight, sleep apnea, unhealthy diet, or exercise lack can be contributing to it. The hypertension guidelines come out and they say that we want an ideal blood pressure at 120 to 129 in individuals. And you start in that case, because it's elevated blood pressure, diet and lifestyle exercises in that proportion of individuals. We went over some of these guidelines, so I won't mention them, but important to detect white coat blood pressure and masked hypertension in these individuals. And here's an algorithm that you can see for sorting that out. Just because in the office their blood pressure is high or low doesn't mean it's high or low when they go home or when they're sleeping at night. So we want to add additional screening for our blood pressure. Secondary hypertension is very important. We don't want to